Ladies and gentlemen, Dr. David Nabarro.
To Alice Chapman-Hachette, thank you very much indeed for welcoming me in such a beautiful way. If I was standing in front of you, you would see that I'm blushing deep to the roots of my cheeks, and I love that, because actually, when I was invited to come and participate in this important meeting of the European Public Health Association, the answer was absolutely, yes, please, I want to be there. And then when I saw the title, From Pandemic to Syndemic, in brackets, new, close brackets, vision for people, health and equity, I thought, yes, I'd love that, especially if I can talk about the vision without implying that it's new. Because here's my main point to everybody. The principles of public health are centrally important in the way humanity reacts to and then responds to COVID-19. And these are not new principles. They are principles that many of us have been brought up with and have worked with for big parts of our professional lives. And the point I'd like to put to you in the next 20 minutes is that actually some of these principles that we've been brought up with have got a bit lost. And that's what we need to remember. And we need to go back and find them again and reintegrate them into our way of working. You see, public health, for me, has always been the key to functioning economies, the key to functioning societies, the key to a functioning planet. And it doesn't mean through public health that we're saying an end to all sickness, an end to all premature mortality. No, but it does mean that we believe in equity. We believe in dignity. We believe in human rights. And we believe in the centrality of the human being as somebody who's learning, somebody who's respectful, somebody also who has a spiritual core. And that must be, I believe, so important at this time. And just to finish, why am I talking like this? I'm late today because I've just come from a meeting where I've listened to leaders from Africa describing their perplexity at actions that have been taken in the last 10 days in relation to travel from Southern Africa and from West Africa to Europe, and a real sense that there's just been an absolute lack of the human decency of conversation between leaders who respect each other. There has not been the conversation between leaders of African nations and leaders of European nations to go through what are the most sensible strategies for dealing with Omicron. Instead, just travel bans, bang, 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 put in place. Or perhaps the more fundamental issue of distribution of vaccines. Where is the public health vision behind the current global vaccine distribution? It's not there. It's some other vision of how humanity should work. But it's not the one that I was brought up with when I started to learn to do public health. So that's where I'm coming from. Let me go into detail. I want to start by talking about the pandemic I want to talk about it from several perspectives. First of all, the way in which the virus itself is behaving and what my colleagues in the WHO are learning about this virus over time. And they're learning incredibly quickly with hundreds of papers a month, but they're learning and they're learning fast. Secondly, what we know about how the virus is affecting society. Thirdly, how services are responding to the virus. And fourthly, what are the political processes that are emerging as we deal with this pandemic? Well, let's start by thinking about the virus. A pathogenic coronavirus. Nothing like flu. Please, please, please don't compare this with a flu pandemic. It's just nothing like it. Coronavirus pandemic. And it's quite interesting. We don't have coronavirus pandemics to learn from. We have SARS, we have MERS, and there are some other coronavirus conditions. There are a number of veterinary coronavirus conditions. And then there's the common cold, which seems to be the atypical coronavirus space. I just want to say this is new and we're learning all the time. But what we seem to have pretty clear is that this is primarily droplet-borne, and that means you tend to get spikes and surges in quite narrow geographical radii and quite tightly located. And most importantly, it's not seasonal waves like influenza. It's very hard indeed to predict and then to understand the periodicity that we see now. But perhaps the most important thing is it's not an even periodicity in different regions. The public health response to this virus is peculiar. I mean, what we've seen in previous pandemics, what we saw in Ebola in West Africa in 2014, 2015, what we've seen in the various cholera outbreaks around the world, is that the principles of infectious disease control very much apply. You find cases, you suspect them, you isolate them, you confirm, you find the contacts, you isolate them, you test them, and through a successive process of case finding, contact tracing, and sympathetic isolation, it's possible to break chains of transmission. And of course, when you've got a lot of chains of transmission and you can't dissect out the chains, then you're dealing with community transmission, and you perhaps have to cut back on your contact tracing. But you never lose sight of the basic discipline of case finding and contact tracing as the way to respond to an infectious disease. And that is then the public health underpinning of disease response. And then the technologies like diagnostics, like treatments, like protective equipment, like vaccines, are all plugged in to the basic approach of case finding, contact tracing, and the use of isolation to break chains of transmission, and then to contain and eventually suppress spikes of disease. That's how within WHO we started on this in January 2020. It's one of the reasons why a number of countries were identified early on and praised, because they put in place case finding and contact tracing arrangements. But you know, that public health capacity being at the heart of the response seems to have vanished from the conversation. How often now, when you listen to governments talking about what they're doing about the pandemic, how often do you hear about the maintenance of case finding and contact tracing? In the UK, it's embarrassing for government and other people to talk about, because there are perceived to have been some difficulties with the scheme that was put in place test, trace, and isolate. But we don't believe that the long-term future of dealing with this virus can be planned without building in long-term case finding and contact tracing and all that goes with it as the heart of the response, which includes the absolute need to make sure that isolation is not seen as a deprivation. Instead, that isolation is seen as something that you do for the good of society, but also something that doesn't cost you a load of money or doesn't cost you your social status as a person. So, number one, the pandemic is very much here with a virus that's pretty well unknown, a pathogenic coronavirus. It's mutating and we don't know where it's going to go. And number two, public health in the public information about the responses has been almost forgotten. And instead, what's presented as the paradigm is often a dichotomy. Do we preserve public health? Do we preserve our health services? Do we pay attention to the needs of the deprived in society? Or do we say the economy is too important, we must keep the economy going at all costs? And do we prioritize maintaining the economy, even though that has some repercussions for public health? That dichotomy is the narrative at the moment in many parts of the world, and we think it's wrong. For us, and I'm talking WHO here, the economy can only be strong. Society can only be strong. Humanity can only be strong if this virus about which collectively we know so little, if this virus is dealt with as a public health challenge and the investments in society favor, indeed prioritize public health with one special additional criterion, and that is that equity is put as number one objective, because as COVID-19 advances, so it's clearer and clearer that it's becoming a problem of poor people and poor countries and the poor world. Having identified some of the challenges with the way in which this is being viewed, and having shared with you that this is a virus that's sticking around, that needs a public health response with a strong equity lens, let's just look ahead at the syndemic and what needs to be put in place for this to leave the world better when eventually it's calmed down. Well, what should world governments be doing? If we were sitting with the leaders of some of the G7 countries, what would we expect them to say to us if we asked them, what's the overall purpose of your response to the pandemic? I don't know. But I would like them to say, we're approaching this pandemic as a global challenge. I'd like them to say, we want to see every action possible undertaken to make sure that there is a fair response that's available for everyone. What we would not want them to say is we're concentrating on the well-being of the people inside our national borders and we don't care about anyone else. And yet when we look at the responses that are visible in Western Europe, we look at the responses that are visible in North America, it kind of comes across that the priority is very much the people within our border. Why else are Western European countries hoovering up as much vaccine as they can, often at really high prices, because they want to store up and have enough for additional boosters, third and fourth, just in case it turns out that increasing the level of immunization can reduce the risk associated with some of the variants. But is that dealing with the pandemic as a global issue? No. It's prioritizing the people of individual countries. And meanwhile, getting assured supplies of vaccines into the global COVAX scheme that was set up at the request of the rich nations in May 2020. But getting vaccine into that scheme is really difficult. And what's coming through is donations often of vaccine that's close to the expiry date, donations on which we have very little advance information. So it's really hard to do advanced planning. But that's not the way to help the world get on top of this virus, to help have a world vaccination program, is to say to African nations, you get the bits that come off the edge of the table when the wealthy nations have got what they need to have their stocks for more booster shots. That's not a global response. That's a national response with bits left over given to the rest of the world. And that is not the way to deal with a global pandemic. And in fact, it goes further than that. We've got nations using vaccination as their primary response mechanism and going for vaccination of children and booster doses for older people, when we have remarkably little information in the World Health Organization about what does happen when you go for total population vaccination coverage. Does that really reduce transmission of the virus? Not clear. Not clear. And what's the challenge if you've got 20% vaccine hesitant? What does that do to your overall effort to get population-wide immunity? Not clear. So all that's happening in Western Europe, in the US, is all experimental. We absolutely don't know what we're dealing with, but what we do know is that the vaccines are amazing at preventing people getting severe illness and death. They're amazing at reducing, therefore, the level of severe illness and death. So one thing that we do know that should be done with the vaccines is equitable distribution across the world so that all people who are high risk of severe illness or death, particularly older people, people with diabetes, health workers and the rest, could all be immunized and have the same protection. And although that is known and is at the center of strategy, that is not the dominant paradigm at the moment. Instead, we've got countries moving into the exciting experiment, but it's a big gamble, of trying to control this pandemic by vaccinating as many of their citizens as possible and narrowing the interval between second dose and booster dose. So, in conclusion, pandemic is due to a stable virus that's here to stay, that's going to go on mutating, and is likely to give us many new variants in the coming months and years. The virus is causing increasing challenges, particularly among poor people in poor countries. The use of vaccination as the primary means to reduce the incidence of the pandemic is not a viable strategy for the world. And whilst it's been seen as possibly a viable strategy for individual high-income nations, it's still a gamble because of the constant emergence of variants that may well have the capacity to escape and continue to cause illness. There's not a global response to this pandemic. It's a piecemeal national response. The role of public health in the response is not being recognized and is certainly not being talked about, except among, of course, public health people. And so I'd like to put to everybody on this meeting, it's absolutely essential for all of us to be clear that a good public health response enables societies to continue, contributes to economy, society, and humanity. A good public health response is key, given all the unknowns about this virus. We should not be relying on vaccines alone to deal with it. We should be combining efforts to reduce transmission through masking and distancing to avoid inhalation of others' exhalations. Plus, we should be ensuring decent public health services, and we should be bringing in people as the response to the challenge and not presenting people as the problem. They are the solution. Goodness me, if there was ever a time for public health to be visible and to be understood, now is the time. And we've got a lot of work to do to get our message across. Thank you for the chance to be here today and share with you. I look forward to the next phase of the conversation.
David, thank you very much for such a moving presentation. I think it has really opened our eyes to the real difficulties that we are still facing and given us a global perspective. And yes, I mean, just listening to you, my heart goes out to how we are treating those African countries and the lack of the joined up approach that there seems to be internationally. I'd like to take 10 minutes more of your time, if we may, and open up the discussion to comments and questions from the floor. And as is the chair's opportunity, I'd like to take the opportunity to ask you the first question, if I may. You've spoken very eloquently about leadership, about vision, about equity, about us all as human beings. These are big, sobering words. You've also ended by saying that people are the solution to this, and that this mustn't be a problem of the poor. Where do politicians fit in that picture? And how can civil society, because all the people listening to you this afternoon are representatives of civil society organisations, how can civil society help? It strikes me there is a lot of work to be done.
Thank you very much. Politicians represent their people. The difficulty is that the politicians in many cases are not getting the full story of what needs to be done to deal with an infectious disease. There's an awful lot of people offering predictions and prognostications who don't know anything about infectious disease control. They're modelers, they're pathogen specialists, they're clinicians. This is a community of public health experts. Please brief your politicians about public health. Remind them it's not the same as hospitals. It's the health of populations. Remind them that the center of public health work is the people themselves and not the institutions and not the technologies. Remind them that public health is about strong societies. Strong societies are as strong as the weakest link. We've not managed to really get a virtuous relationship between public health risk professionals as the professionals who focus on the well-being of society, and politicians, the people who represent society. All sorts of other influences have come in, and that has meant the politicians have not got the anchor of the basics of disease control to inform them. Thank you.
Thank you. A very clear message there. I can see one hand raised and I have two questions coming in on the chat. I'll start with the chat questions first. Can you elaborate a little bit more about the views of the WHO, David, around indoor ventilation and filtration systems? I'm very conscious that we are now aware that this is an airborne disease. Are we approaching it from the wrong angle? Should we be focusing on indoor air quality rather than vaccines, rather than masking? What are the views of the WHO on that?
So there's been a huge amount of discussion about whether or not there can be aerosolized transmission or whether it's still big droplets. And the view is that in the majority of situations, it's big droplets, but there are times when it can get aerosolized and go airborne, particularly in places where ventilation is done through bulk air movement without filtration, particularly in ships, perhaps sometimes in prisons, in big factories. And also there are settings where aerosolization is more likely to occur, such as when people sing, and of course, when procedures are done where there is a lot of spray. I think that for us at least, it's not a debate. There is both droplet spread and airborne spread, and ventilation is crucially important. And I think WHO is trying to find the right way to offer the best possible guidance for ventilation, knowing that this can become an absolutely massive area. And I think that, well, actually, I'm not going to say any more than that because I'm not part of the people who are involved, but there has been a real recognition of the need to shift. So in just simply dealing with the question as written in the chat, this is now much more strongly in the WHO's positioning. And here's what they say. You need decent masks, well-fitting, not just any old cloth, but proper surgical masks. You need the physical distancing, but particularly to avoid inhaling the exhaled air of others. You need ventilation, particularly in confined spaces, in order to reduce the risk. And that's especially the case with some of these high transmissible varieties. You need hygiene, cough hygiene, surface hygiene. You need to shield those who are most at risk, and their immunological shielding is so good and desirable, but you also may need to combine physical and immunological shielding. Those 5 activities taken together are the right response, not vaccines on their own as the total get out of jail free card, but it's all 5 together where vaccines are part of the response, but not the whole of the response. That's what WHO recommends, particularly Maria van Kerkhove, who is the chief epidemiologist, and Mike Ryan, who's the head of the Health Emergencies Programme. Thank you.
Thank you. Again, a very clear message. It's not one thing, it's a combination of things. Moving on to another question. How can public health help in the COVAX effort and make sure that the vaccines that we are sending around the world are not the ones that are about to expire?
There's only one way, and that is all of you who know about the management of immunization programs, especially those that use hypercold products, just be very clear. These are hard to organize anywhere. And it is really tricky to then add to the burden of the people who are organizing them in low-income settings. The 2 additional challenges. One, receiving any old vaccine, and 2, receiving vaccines that are within 6 weeks of their expiry dates, which is quite common now. And just stress, it is absolutely unreasonable to put this on people. Just look at the situation in the UK, where we've got GPs saying they're being asked to do booster vaccination. They're just going to have to cut back on their normal levels of care, particularly for people who are high risk, because otherwise they can't organise the booster programme. Well, if that's the case among GPs in affluent UK, what's it like for my friend who's head of the medical stores in Uganda, who has to go to the airport now just about every day because he feels there might be a donation from an NGO or from a government on a plane, and they get absolutely hopping mad if he's not there to receive the donations. And he's got to be there because he's the only one who can really take responsibility for how it goes into the cold store or how it goes into the record keeping, especially if there's short expiry date. It's absolutely appalling what this donation mania is doing for the workforce in many developing countries. Back to you, Alice.
Thank you very much, David. I did see that there was a hand raised earlier. Mariella, indeed. Mariella Catalano. Are you still there? And do you still have your question that you would like to ask?
Thanks a lot. Just very shortly, the vaccine are the results also of public research, and it doesn't appear so much. Probably there is a need of a position, a common position by the international societies supporting what WHO say about equity, because the companies are in a sort of extortion concerning vaccine with all of our country, but one of the main input were given by research, the public and the university research. The second point is, I guess, is extremely important for all our country, that communication by WHO arrive on the relevance of covering low-income country by vaccine, because also using not the generous part of us, but also the egoistic part of people to understand that just having around the vaccine we can solve this problem. And the very short point, probably is a stupid point, excuse me, but I think when a vaccine is registered by the FDA or by the EMA, why don't try to force to put as a rule that together with the efficacy of the drug, the company have to give a program on which percentage and on how cover also the low-income countries as a request for all the registrations. So probably is a impossible question, but it would be.
But they're not impossible, Mariella. That is the heart of our work. The thing is that none of these questions have easy answers.
Yeah, sure.
So it's difficult to put the question and the answer into a tweet. But COVAX was set up so that it wouldn't be necessary to make these choices. COVAX was set up so that all countries could access vaccines at a negotiated price. What happened was that during the early months of this year, a number of governments got really scared. They thought that the proof of your utility as a government was proportional to also your capacity to get a clear supply of vaccines from manufacturers and to implement the vaccination quickly. It became a sign of virility for a government to have a load of vaccine in stock. And then there were some governments saying that others were slow because they had different regulation procedures. So there was a degree of ridiculing of those who were slow. And what did it do? It sent a lot of governments running to the companies, offering the companies a higher rate per dose to buy vaccines and to bypass the queue. And right at the middle of the queue was COVAX. And so what happened is that desperate governments, eager to satisfy their constituents, went to the companies, offered more money, got more vaccine, and that in turn led to a slowdown in vaccines going to COVAX. It was simply that anxiety of political humiliation. And of course, it was impossible for the companies to refuse. If you're being offered 10 times more on behalf of your shareholders, you have to accept that. So there is still something wrong with advanced purchase schemes. And we've had it before. I've been involved in other pandemics when there's been an urgency to access vaccines and then competition started. It's really, really hard to control this, but that's what I understand has happened. So yes, you can have a rule that says a percentage should go to lower income countries, but in the end, holding that rule is very difficult. I mean, you saw AstraZeneca got all sorts of court cases and things like that. So it becomes really difficult for the companies. I do want to rise to their defense. And some people say, well, it would be much easier if all the intellectual property was given into a pool. And yes, that's a good theoretical thing, but actually on this one, there's not been widespread support for pooled intellectual property. And that's meant that discussions around having an alternative way of dealing with the IP has not really moved forward. Lastly, there's, of course, a lot of these vaccines have been discovered through public research, and there's big legal debates underway about whether or not enough money is moving from the private profit takers into the public sector. I don't really want to mention the companies, but there's one active court case on that. I can't comment, but it's one of these issues that is constantly needing to be looked at. And lastly, yes, I think that always one can say WHO should communicate better on why it is economically, ethically, and public health-wise essential to immunize the world and not just to concentrate on individual countries. But the alternative narrative of we must look after ourselves first is quite strong as well. And penetrating with our WHO narrative is not easy. We do get pickup. We get pickup, particularly in the newspapers and TV channels and so on that are sympathetic to our position. But there's a very, very strong populist energy in Western Europe, in North America, but in many other countries too. It's very fashionable. And that populist energy has become very dominant in discussions about vaccine access. All I can say in finishing is that our message, the one of it being desirable to take a global perspective, is correct. It's not wrong. It's essential that it is articulated strongly, and it is the right message for the future. And so we just have to continue saying what we're saying and doing what we're doing. It's not woke, it's not cancel, it's none of these bad things that people identify. It's actually what's best for the health of everybody in the world, for my grandchildren in the UK, for your relatives wherever they are, What matters to all of us is that the world gets this pandemic under control, and not that individual nations get this pandemic under control, simply because of the capacity of this virus to mutate and to form variants that can do all sorts of things. And we are nowhere near the end of the variant story on this virus. Thank you, Alice.
Thank you so much, David. We have been incredibly honoured to have you with us today and for you to share your time, which is increasingly valuable, particularly as we are going through the next wave of this and the next variant, which we didn't even know about when we started planning this session. So I really do appreciate you giving up your afternoon to be with us today. Thank you hugely. You've been a truly inspirational speaker to us and really made very clearly that link between politics, economy and public health, and that the world needs to act. It's a global problem. It isn't an individual nation state problem. And I'm glad also that you raised the word populism. I wasn't going to bring it up, but I think it unfortunately plays into this discourse as well. And the shift in our global politics is being mirrored by how we are treating this pandemic. So thank you for making those points incredibly clearly, incredibly passionately. There's a message in there for all of us as EPHA members that there is a huge amount of work still to be done. So I'm aware that we have had a lot more questions coming in. Unfortunately, David has to leave. We have borrowed enough of your time as it is. Thank you.